they have given the talk. This is again, they are with us. They are going to give us a talk and give their experience and share with us. Earlier, we learned a lot from them, and still we are going to learn. That is why we are inviting him, and we are going to listen to them. Their enthusiasm and energy to teach is very phenomenal. Their complex concepts and theories through clear explanations made it easy for us to understand. We are happy and fortunate for them to accept our invitation without any hesitation, and we are really grateful to them. It is an honor to welcome Dr. Fernandes from Switzerland and Dr. KRETTEK from Germany. I think I will not going to tell about their CV. Our Dr. Kumar is going to talk about introduce them to our delegates. Dr. Fernandes is an international consultant in hand surgery and upper extremity surgeon and pioneer in hand surgery. And KRETTEK is a trauma orthopedic surgeon from Germany. And today, they are all going to share their experience with us in elbow trauma. And we have some more faculty from our state. ANIL PATIL, orthoscopy surgeon from Belgaum, and SHANKAR KURPAD from Columbia Hospital, Bangalore, and PURUSHOTHAM Lodge, First Hospital. I think they are going to share their case with us and discuss the case, and we expect discussion from our foreign speakers, much involvement. And we have Dr. Rajeev Naik, Ajit, Kumar, they are going to moderate the session. And in the panel, we have Dr. Vishwas Mundewadi from Bijapur, he is the HOD of Organised Medical College. And Ashwin Kumar Singh, I think is there, I hope he is there, from Ballari. He is right now President-elect of our Karnataka Orthopaedic Association. He is with us. Roshan Kumar, past Secretary General from Raja Medical College. He is with us. Madhukar from Karwar. He is HOD of Karwar Medical College. He is with us. And Dr. Vamsi, Satish is the Joint Secretary of our association. Vamsi, they are both coordinating the session, and they are helpful to me to organize this webinar. I am very grateful to them for organizing, contacting people, and doing the work. Finally, I request all delegates to ask the question only in question and answer section. That will be taken up during the end of the session, during the discussion. Thank you very much. Dr. Uday Kumar, he will take over and introduce both foreign faculty. Thank you. Please, Dr. Uday Kumar, go ahead.
Yeah, thank you, Dr. Chandrasekhar. Vamsi, the first slide. Vamsi.
Can you see the slide?
Yeah, I can see. Can you go to the first slide? First slide.
Yes.
Yeah. Thank you very much, Dr. Chandrasekhar. And it is my honor and privilege to introduce the international faculty and local faculty. Next slide, please. Vamsi. Next slide. Professor Diego Fernandez is a devoted upper extremity hand and trauma surgeon. He is an honorary professor of orthopedic surgery, University of Bern, Switzerland. He is a visiting professor of the Harvard Medical School, Massachusetts General Hospital, Boston. He has worked with Dr. Harold Boyd and Dr. Lee Milford at the Campbell Clinic, Memphis, Tennessee. He worked with Professor Maurice Muller in Bern, Switzerland. He has written over 160 articles and book chapters. Next, please. Together with Dr. Jesse Jupiter, Professor Fernandez has written a book entitled Fractures of the Distal Radius, A Practical Approach to Management. He is a member of the American Orthopaedic Trauma Association He is a member of the American Academy of Orthopaedic Surgeons. He is the founding member of the European Wrist Arthroscopic Society and many more. Thank you, Professor Fernandez. We welcome you to the webinar.
Thank you very much for the kind words that you said. Thank you. I'm happy to be with you again.
Thank you, sir. We also have Professor KRETTEK, who will be joining us a few moments later. He is a professor of trauma and orthopedics from the Hanover Medical School, Germany. He is a trustee of the AO International. He is the chairman of the Computer-Assisted Surgery Expert Group of the AO ASIF. He is an editor of Techniques in Orthopedics, Journal of Orthopedic Trauma, Injury, Journal of Computer-Assisted Surgery. He has about 778 Medline listed publications. Next slide. He has special clinical interests and research focus on computer navigation and robotics, late reconstruction of articular trauma, bone defects, limb lengthening using motorized nails, and joint transplantation with large allografts, and has done work on 3D printing in orthopedic trauma. Welcome, Professor KRETTEK. He will join us a few moments later. Next slide, please. From Karnataka, our faculty, we have two moderators, Professor Rajeev Naik, past president of the Indian Orthopaedic Association, Bangalore, Dr. Ajit Kumar, who is from Tejaswini Hospitals, Bangalore. Next, please. And our faculty are Dr. ANIL PATIL, from arthroscopy surgeon from Belgaum, Dr. SHANKAR KURPAD, a consultant surgeon from Columbia Asia Referral Hospital, Bangalore, Dr. PURUSHOTHAM Lal, consultant orthopedic surgeon from Sparsh Hospital, Bangalore. Next slide, please. And our panelists for the program, Dr. Vishwas Mundewadi, professor and HOD from Alamin Medical College, Bijapur, Dr. Ashwin Kumar Singh from Bellary, Dr. Roshan Kumar from Rajarajeshwari Medical College, Bangalore, Dr. Madhukar, professor and HOD, Karwar Institute of Medical Sciences. So these are the faculty. Thank you very much. And now I hand over to Professor Rajeev Naik to start the session and moderate. Yes, Professor Rajeev Naik, sir.
Thanks, Uday. Without wasting any more time, it would be my honor to request Professor Fernandez to give a talk on C3 fractures of the distal humerus. Sir, it is yours.
Okay, dear colleagues, good afternoon. First of all, I would like to thank Professor Naik for inviting me to accept to talk in this event. And it's a great pleasure to be with you all again in this occasion. So my first talk is on distal humerus teeth fractures, management evidence, and complications. As you all know, 58% of all the humeral fractures are C-type fractures. And remember that you have a three-plane morphology, this transverse in the supracondylar area, sagittal plane, intercondylar, and sometimes you may have also a coronal split in the frontal plane. And there are different patterns, as you can see here on the right side of the slide.
Professor,
the preoperative.
We have to share the screen.
We have not yet seen your screen.
You see?
We have not yet seen your slides.
We are not
okay.
seeing your slides, sir.
Oh,
Please share
okay.
your screen.
Please share your screen.
Okay.
The bottom green button. Share screen.
Share, huh?
Not yet, sir.
Sorry.
Vamsi, please guide Professor.
Yeah. Professor, can you see the bottom share screen button, green button?
No.
You don't see it? Yeah, try again.
At the bottom of your screen, there is a green button.
No.
Sir, if you can move the cursor down at the bottom of your screen.
Yeah.
Yeah, if you move the green, this thing will be visible. You can press on that share.
Prof, why don't you just click on escape, then you'll see the whole menu. Click on escape.
Yeah.
Now you can see the bottom share screen button. The green one, can you see it?
No.
Sir, move your hand on the computer.
Can you see it?
Wait a minute.
Yeah.
Hello? Hello?
Why don't you just close the Zoom and then relog in again? Can you just close the whole screen and relog in again?
That's a better idea. Because he saw his video that time. It was no issue.
No, he has checked his slides, he has checked his video, he has done everything.
Recording stopped.
See, normally when you move the cursor, the share screen comes.
Easier, we'll just check with them.
Yeah, I think he started. Yeah, Professor has started. Yeah.
Minimize those screen. Professor, you can go to the folder with the PowerPoint. You can just leave that.
It's come. It has come.
Yeah.
Yeah. Good. The slides have come.
Yes, Professor. Yeah, you can go ahead. Yeah, we can see the screen.
Do you hear me?
Yes, sir.
Yes, sir. We can hear you.
Recording in progress.
You can go ahead, Professor.
I start again. Eh?
Yeah.
Okay, so we speak about distal humerus type C fractures, management, evidence, and complications. As you know, 58% of all the distal humerus fractures are type C fractures. They have a three-plane morphology, as you can see there, transverse in the supracondylar area, sagittal in the intercondylar area, and you may have also a coronal split in the frontal plane. In the preoperative evaluation, you have to estimate the ability to fix the fracture using CT scans and 3D reconstruction. You have to consider timing, be sure that you have available implants, and the preoperative evaluation of the patient includes the overall operative risk, comorbidities, medications, and functional status. 3D reconstruction facilitates a clear analysis of the fracture pattern, the displacement of fragments, and also the number of fragments, very important for the tactics of the operation. We operate them in the lateral decubitors or in the prone position. The most important thing is to have a flexion of the elbow over 90 degrees and be sure that you can access to imaging. If you're treating a non-union or a fracture with a lot of bone defect, you have to be sure to prep the iliac crest at the same time. What about the surgical exposures? It depends on the fracture morphology. For example, what you see there, in combination with the trochlear area or a very low supracondylar intercondylar fracture, we will use a olecranon osteotomy or a modified approach with the anconeus flap and olecranon osteotomy. For a distal humerus simple fracture or malunion, supracondylar malunion, you may use midline tricep split or also a triceps flap elevation. And if you have a coronal split in the frontal plane and nothing else but that, a non-union of the medial or lateral column, we will use a direct lateral or medial approach. The most important thing when you start the operation is to release the ulnar nerve. Remember to mobilize it 6 centimeters proximal and distal to the cubital tunnel and release distal intermuscular septum. Remember also not to do too much traction on the nerve. Here we're showing the modified olecranon osteotomy approach with the elevation of the anconeus muscle. This was described by Altwell and Rispoli and Steinman in 2006. This one respects the innervation and the vascularity of this muscle. Then, having done the olecranon osteotomy, you can elevate both things together, the triceps and the anconeus, in one block, exposing the distal humerus. The operative tactics haven't changed so much since 1969, and in the first AO manual, you see the 3 basic tactical steps of the operation. First, to reduce the articular fragments. This one shows, very interesting, to do the inside-out drilling, to have a centrally placed drill in the trochlear area, with, as you see there. Then the second is the provisional fixation to the shaft with the K-wires, and then finally the final fracture fixation with screws and plates. This is my first distal humerus fracture in 1976. I was a chief resident at that time. Our chief, Professor Miller, liked to fix the olecranon osteotomy, as you see there, with a 6.5 cancella screw. Is a lag screw that has a very good grip in the intramedullary canal by virtue of the size of the thread. And at that time, we used 3.5 1/3 tubular plates in the 1990 position. And here you see the result at 5 months after the operation. Then 21 years later, this is the 1990 edition of the AO manual. See that they're using also the same tactical steps, but now you see that already we have the plates that we're using the 3.5 third tubular plate and the reconstruction plates. What about the biomechanics of skeletal fixation? Remember, it's important to reestablish the bony architecture, and medial and lateral column compress and stabilize the trochlear fragments. This can be done by parallel plate positioning or by 90-90 or perpendicular plate positioning. The parallel plate position was described by the group of the Mayo Clinic, while the 90-90 with a medial plate and the posterolateral plate was popularized by the AO school. Here you can see that two classic disruption with the medial and lateral column and fragments of the trochlea in the center. In this case, we used, after reducing anatomically, 3.5 millimeters and LC-DC locking plates. So now we already have a much more stable fixation of these fractures, especially in the osteoporotic bone. So are the locking plates necessary? I think this is a major step forward in the fixation of osteoporotic fractures. And as you see here in this example, these has been used. In this case, we have used the plates also in a 90-90 positioning. However, locking plates are not necessary if you have a bone density which is within norm as in very young patients. So if you don't have access to very sophisticated modern plates, remember that the non-locking plates, the screw holding power is perfect in the young patient, and you can still use them without problem. In this paper by Corradi and associated, no significant difference between the two methods of fixation were found, but the patients that were operated were all young, so the quality of bone was very good. They didn't find a difference between one-third tubular plates and locking plates. What about 90-90 versus parallel plating, and what is the evidence? These are a couple of papers that I pulled out to look at this, and in that paper by Corner et al., they found in biomechanical testing the 90-90 positioning of the plates, they have better stiffness to torsion and anterior-posterior bending. However, Stoffel and in 2008, they found better results for parallel plate system, especially on osteoporotic bone. There is fair evidence to support that the use of dual plates, either perpendicular or parallel, in the treatment of both column fractures of the distal humerus. The clinical experience and biomechanical evidence reveals no major advantage between the two ways of doing it. And very important is probably the biomechanical testing to failure may not reflect loading in the patients. So remember, when you operate these fractures, the most important thing is anatomic reduction and alignment as the first step. Then you have to optimize the fixation of the distal fragments to increase stability, especially of the trochlear and capitellar fragments. So every screw you can engage as many articular fragments as possible, as you can see there. Remember not to let both plates to end at the same level at the area of the shaft, and make sure you have a good reduction anteriorly. So maximal stability will allow you then for early motion in the postoperative period. The reconstruction problems that we've seen is the severe osteoporosis, the presence of small fragments with significant comminution that will lead to early implant loosening. This is the kind of situation, you have that amount of comminution of the joint surface. This is actually non-reconstructable, and therefore, for those cases, it's recommended to do a primary total elbow replacement. So the indications would be the older age, if you have already degenerative changes, limited functional demands, and as I said before, non-reconstructable joint surface or bone loss. What are the complications of the type C fractures? The first one we don't have to forget is the ulnar nerve neuropathy, then the mechanical failure and early failed fixation, non-union or delayed union, wound problems, soft tissue problems, infection, heterotopic ossifications, and elbow stiffness. What about the ulnar nerve neuropathy? Remember, the handling of the nerve is important. As I said at the beginning, it's important to mobilize it 6 centimeter proximal and also distal to the cubital bone. And don't pull too much on the nerve during the operation. Subcutaneous transposition is only recommended if the nerve remains in direct contact with metal, posteriorly to the medial epicondyle, or when you have preoperative symptoms already. And sometimes in non-unions with a stiff elbow and a mobile flail non-union, most of the time you have a preoperative nerve problem already. So if you look at this paper in 69 distal humerus fractures treated with internal fixation, in 47 they did an anterior subcutaneous transposition. 22 cases put the nerve back into the cubital tunnel. And 14 patients out of 69 had postoperative ulnar nerve dysfunction, and there was no difference with the way the nerve was managed. Let me go front. And this other paper by Chen, 2010, 137 patients with internal fixation, had 48 had anterior transposition, 89 had the nerve back replaced into the column. There was ulnar nerve dysfunction in 33% of the patients with transposition, and only 9% where they were left in place. So it's very difficult to say whether or not these nerves that were manipulated too much for an anterior transposition was suffering too much traction. In the systematic review of the literature, in this paper by Naut and Associate, they found that there is evidence to recommend anterior transposition for patients only with preoperative symptoms. Incomplete evidence of managed transposition or replacement back in the cubital symptoms. I think it's a microphone that's bothering.
You can go ahead, Prof.
Okay, now we come to the mechanical failure and early failed fixation and non-union. The problems are the wrong implant choice, the inadequate surgical technique, failure to graft bone defects, early infection, and inadequate postoperative management and non-compliant patients. So with all these parameters, you may have a problem with mechanical early failure in the treatment of these fractures. What about the electron osteotomy? In 1990, those were the technique of the chevron type of osteotomy that increases the contact surface, and it's actually per se a much more stable situation. The two ways of fixing it was, as I said before, the cancellous bone, 6.5 cancellous bone lag screw, or K-wires, and both with tension band wire. This olecranon osteotomy usually offers the best exposure of the joint, but we have concerns, and that's the non-union, the wire migration, and the screw loosening. As in this case, you see there the gap after 10 weeks post-op. So, the tips for a successful tension band wiring, according to Jesse Jupiter, are these. First, to aim the wires to the anterior cortex. Then we pass a not very thick wires, we use a 0.6 millimeter wire to a thick needle distally. And then we we create the figure of 8 typical wiring technique. But the thing is that in spite of using just one thick wire, it's better to use 2 thinner wires as seen here. Remember to tighten simultaneously on both sides to distribute the compression force equally, and bend the wires to 180 degrees and embed them into the proximal part of the olecranon. So this is the way it looks with the wires embedded and anterior purchase of the cortex, 2 wires, and very good embedding of the proximal ends of the 3 wires. But remember that you also have olecranon fractures and osteotomy may be also fixed now with proximal locking plates, especially when you have a non-union problem or an associated proximal fracture of the ulna. So here's an example of a patient with a low supraintercondylar fracture treated with conventional tubular plates. This is a patient with 73-year-olds with osteoporosis. So here we have an implant loosening at 8 weeks, and you see that's wrong implant choice, implant loosening. We should have used the locking plates, as it has been done now here for the reoperation. And you see that even with a locking plate for the proximal ulna, you still have a delayed union at that area while the distal humerus fracture is already. But the patient had no complaints and the osteotomy healed eventually at 15 months. The last thing I will treat is the distal humerus non-union. Remember that the options are open reduction, capsular release, internal fixation and bone grafting, and total elbow arthroplasty if it's not salvageable. All of these other techniques, Illiceroff, allograft, distraction arthroplasty, and arthrodesis are also options, but they're not frequently used. Probably the mostly used is the Illiceroff technique for infected non-unions. The tactics are the ulnar nerve release. We use the olecranon osteotomy approach to treatment as a non-union. You have to do a capsulotomy anterior and posterior, but usually you have elbow stiffness and a failed supracondylar non-union. Realign and fix internally. So usually by open the medullary canal, and if you mobilize the distal fragment posteriorly, you can do the anterior capsule release through the non-union side. Otherwise, you have to do a conventional arthrolysis. Here's an example of a patient very badly treated, ended up in a flail elbow non-union with a contracture, and was treated with this way as a fresh fracture with the same technique, double plating. And here post-op with good movement, and you see that we don't have a problem with the olecranon osteotomy. It's a lot of authors have been published now that we have problems. Probably the best paper to read still is the paper by Helfet, Kloing, and Howard Rosen from 2003. They had, with these way of doing things, 90% of bone-in unions and no non-unions of the olecranon osteotomy, with good functional results. So even in the very osteoporotic bone with the locking plates, remember, if you have that kind of bone defect, you have to do a bone grafting at the same time. And you might get, even with it, a lot of osteoporosis, a good functional result. So this is my relevant literature. If you want my slides, Professor Naik, you can have them. And I won't bother you with this, but there's important reading. So this is the last case I would like to show you. This is a supra-intercondylar inveterated non-union. She has a flail elbow, capsular contracture, and degenerative changes. And I thought that I could do, this is the way the elbow looked, completely failed. It goes into all directions. And this is the way we treated the patient. We resected the radial head because there was some degenerative changes at the radiocapitellar joint. Did this, but the intra-articular incongruity was there. We had avascular changes of the trochlea and also degenerative changes. So despite having this preoperative motion, total elbow replacement was performed, and this is a result 3 years after the operation. At 10 years post-op, the patient comes back with repetition pains and rotational instability. So remember that complications after elbow arthroplasty are often more severe and difficult to treat. So we had to revise them like this with additionally lateral plate to increase stability of very thin. It's actually like treating a pathological fracture with plate and cement and a central endomedular. This is 3 years post-revision, and the patient is very happy with the final result. So to finish off, I would like to say that there's substantial progress in distal humerus fracture management, but we require a good indication, very good surgical technique, and the post-operative measures should be also added. The flail distal humerus non-union arthrolysis, but we can avoid arthroplasty if stable fixation is obtained. And a stable elbow with restricted motion is perhaps better than a total prosthesis in the post-traumatic etiology. Thank you very much.
Thank you, Professor. Dr. Raju Naik, are you there? Raju Naik. One sec. Sorry.
He is muted.
Yeah, one sec. Dr. Ajit, sir, you can start. Professor.
You want Dr. Rajeev?
Yeah.
So, Professor Fernandez, sir, what do you do with the loose osteochondral fragments when you open it? How do you, any tricks to put it back?
If they're big enough that can be screwed back in with a headless, very small headless screw, that's a way to fix them. At one point, they had the Etty pins. They're from Eddie Pons. I don't know if you remember that. They were resorbable pins that you could fix very small osteochondral fragments using also the bone glue. So I think it depends on the size. If you have a osteochondral central fragment of the trochlea, but the periphery of the trochlea is intact, you can just resect and leave the defect there. You can bone grafting a little bit more proximal to the level of the chondral surface. So that usually fills up with fibrous tissue. The most important thing is to maintain the distance of the trochlea and do not compress. So that's why in the first slide I showed you, first AO manual is a screw. You don't put a lag screw, but you put a screw that you don't let, you have to cut the thread with on both fragments so it doesn't compress, it just maintains the distance.
I have one question.
You can ask your question.
Yes.
Yeah, Dr. Fernandez, what is the incidence of non-union in your series? Alicronon non-union.
Non-union of supracondylar intercondylar fractures, it's very low. It's about probably less than 1%.
How do you manage those non-union?
Well, as I said before, if it's an atrophic non-union, we'll do an internal fixation back with the same techniques of a fresh fracture, probably using locking plates or modern systems. And if you have an atrophic non-union, you have to add an autologous bone graft.
Do you use the bone graft?
We use a bone graft from the iliac crest,
Oh, thank you.
autologous. I don't think that bone substitutes. I prefer to use a very good osteogenic material from the same patient.
One more question. When to start elbow mobilization?
Depends on the residual stability. That if you're happy with the fixation you have, and if you have very good bone quality, if a young patient, you can start right away. As soon as the soft tissues, put them in a splint just for the soft tissue for the wound, and then have the physiotherapy do assisted active exercises right away at the 24 hours, 48 hours later, and you maintain the splint during the night for the first 10 days. And if the patient is walking for a long distance, probably you choose a sling to hold the elbow a little bit.
In osteoporotic patients?
The osteoporotic patients, that's the same, I would say, with much more physiotherapy control. Don't let them go. If they're not compliant, the patient, they start moving, usually elderly patients, they don't have too much pain, and those are the ones that might end loosening up the screws. So you have to protect them more and have the physiotherapy an eye on those patients. But it's basically the same management, the same protocol.
Okay, thank you.
Yes.
Professor Fernandes, could you hear us?
Yes.
Yeah, there are two questions from one of our residents. He wants to know whether every posterior approach you need to see the ulnar nerve, dissect it out of harm's way, or whether triceps itself will protect that nerve. That is one question. And secondly, he wants to know what is the role of hinged elbow brace in such circumstances.
The first question was if we expose the ulnar nerve in a tricep split.
No, every patient of posterior approach to the elbow, you need to look at the ulnar nerve and sort of dissect it 6 centimeters above and 6 centimeters below, as what you said, or or it gets protected by the tricep split in case we do the tricep?
Yeah, no, the tricep split is probably protecting the nerve. But the tricep split I would use only for very simple situations. For example, the most common would be a varus deformity, an osteotomy. You see that you don't have acute fracture edema, which is a problem. In the acute fracture situation, you have soft tissue swelling. In an osteotomy or in a non-union, perhaps just supracondylar, that you need to put 2 plates and that's it, and not mobilize too much the soft tissues, then you might probably get away without exposing the nerve. And the second question is what?
Was a hinged elbow fixator.
Hinge elbow fixator.
Yeah.
I will show you something in the radial head thing, but you can use. I haven't used a hinge. My personal experience is 0. Okay. I have used static fixation, external static for 5 weeks without problems. And now you have a dynamic internal elbow stabilizer, which is it's a very simple system, and it's internal, and you don't have all the pins going around, a very clumsy thing of the hinge fixer.
Okay, thanks.
But I might show you that on my next talk.
Okay, Ajit, you can take over. Good evening.
Good evening. Yeah. I think without wasting much time, we'll go on to the case discussion by Dr. Shankar now.
Good evening. I hope slides are visible.
Start from the first slide.
Yep. Okay, now it's clear.
Yeah, go ahead. Let us see.
Yeah. So after that excellent discussion on supracondylar and intercondylar fractures, we've had certain nasty experiences with our own set of supracondylar, intercondylar fractures. The issue is not with relatively straightforward fractures like this or this. The question that we sometimes need to ask ourselves, are all supracondylar distal humerus fractures equal? And we realize that it's probably not. We have enough number of classifications. By and large, the problem is that they're limited value in real life. They're supposed to help us for an optimal plan, but in reality, they probably don't. The AO classification is excellent, especially for discussion. It's excellent for comparison, but on table, it probably is not all that great and useful. The Riseborough and Radin, definitely it's got its place. But I think I would draw attention to this, because this is something that really brings attention to what we have trouble with on table. If we believe that roughly about 55 to 60% of all distal humerus fractures are having a significant intercondylar component, a type C fracture, then this actually is what we should be focusing on. Now, the headache is not with these fractures. The headache is with fractures where the entry into a column is very low, either a low lateral or a low medial exit. Now, these two are lambdas. The lambdas are based on the side where it exits high on the column. So this is a high lateral exit lambda and a high medial exit lambda. Similarly, you also have trouble when the exits can be on both sides very low, true transcondylar fractures, or sometimes varus valgus injuries or so-called abduction adduction injuries. All of these injuries are very difficult to sort out because the column length on that particular side is extremely small. So, for example, a transcondylar fracture gives you practically no space to put your standard screw system or your locking plate system. These are the headaches that you really wish that you had some other plan for. Now, in terms of management algorithm, well, you modify this and then you have basically an exposure-based algorithm that's there with you. And of course, the fixation plan, I think Professor Fernandez pointed out very clearly what's the best way to go. Now, the goals are fairly clear. Restore the joint surface, restore alignment, stabilize the joint to the shaft, and the fixation has to be stable enough for us to get early active mobilization. The principle is that you have a lateral column, medial column, and of course, you hold them together. This is, I think, an often used slide of the two columns to hold them together. And of course, in this August gathering, there isn't a real point in discussing O'Driscoll's technical objectives. The principle is one of achieving two-column stabilization, and that hasn't really changed from the 1960s. The question is, the technique of doing so did change. So initially, it was about using standard plates and screws, and then it came to lock plates and screws, and then the question of 180 system rather than a 90-90. The humble tension band should not be forgotten. We use the tension band more or less every single day while we sort out the olecranon osteotomy. But sometimes it can be useful and a bailout option when we deal with very low exiting fractures in the columns as well. This is an example where both columns were fixed with tension bands. Here is one where I had an abduction pattern fracture where the lateral column exit was very, very low. There's absolutely no space for me to get even a 2.4 mm based locked plate system on this side. So that was completely out of the question. So the best thing to do was to stabilize medially with this, and on the lateral column, use a tension band fixation. And it heals wonderfully, because at the end of the day, as long as you've respected soft tissue, as long as you've respected the anatomical requests and requirements, it's more than likely that it will behave itself very well. Something like this is a slightly more challenging situation where the anatomy is significantly disturbed and you've got comminution on one column, this being the medial, and the lateral column exit is again fairly low. on table, this is what we had. So what we did was reconstructed the columns using screws to build the column up and then tension bands to hold it together. And of course, the ulnar nerve is protected at all times. That's a range of motion at roughly 3 weeks or so after she started her active range of motion exercises. That's about 6 weeks after surgery. This is her X-ray at about 3 months. It's not, it doesn't look as elegant or as fantastic as an X-ray with lock plates and screws. But moving from that to this is, I think, a deed in itself. And of course, getting movement, because it was a young lady, she put in the effort and got the movement out of the elbow. Another situation like this, where we have a shaft fracture, which is a short spiral, and a comminuted distal humerus fracture with a low exit on the lateral, this being a medial lambda, low exit lateral, was a real challenge and nightmare. So we planned and ultimately went in with a bucket load of tools and tools from our neighbors as well. And that's ultimately what we did. A olecranon osteotomy, lifted up the triceps all the way up, exposed the radial nerve as well. The ulnar nerve is fairly safe, obviously. Plated the humerus shaft so that I've got a stable shaft to work with, and then addressed the rest of this over here. Again, here, the articular surface was reconstructed first. The column that was platable, in my opinion, was plated next. And then, since anyway, the lateral column was held onto the shaft with wires, that was just completed with tension band wires, like that. And of course, these things do go on to heal fairly well. And that's the sort of range of motion that we can achieve with that, because the stability of the fracture that you've achieved is fairly good on day one. So once the soft tissue settled down, I mean, considering that it was an extensive surgery, once the soft tissue settled down, exercises started off at roughly about a week or so when she was comfortable. And then we went on with movements to achieve this sort of movement at about 2.5, 3 months. Literature does support this. And this is what I put up here. So there's, in fact, literature that compares double tension band wires versus double plate techniques. And the results were equivalent. Now, this is very strange because we were constantly fed information to believe that plating techniques are far superior to tension band. This may obviously need a pinch of salt, in the sense there seems to be a selection of cases here which tended to not have column comminution. Now, there is enough and more literature which again attests to the fact that definitely a tension band based osteosynthesis in low exiting fractures on one column or both columns is a valid method to bail yourself out of the situation. Without doubt, the cost effectiveness in our Indian scenario with our extremely cost sensitive patients is, I think, something that I don't have to emphasize upon. I think the take home with our experience on this sort of situations have been that we have our goals well defined. We obviously have to honor the fracture fixation principles and the methods of stabilization of the distal humerus. You can't change that. When we are faced with low fractures, with little or no distal column for us to plate, then in these selected situations, a tension band wire technique is a fair solution. At the end of the day, during our surgical tactic, we do follow this. That is, you reconstruct the articular surface first and marry the articular surface to the columns. During that act, typically most of us, if I would dare to say so, all of us would initially have a tentative fixation with K wires, and then we proceed towards the standard plating that we are comfortable with, be it conventional, be it 90-90 locked or coplanar locked systems. Or if you're faced with the situation where you don't have enough distal hold, then you may as well opt for a tension band on that side. Because ultimately, all said and done, this is the sort of outcome that all of us would love to achieve. Thank you very much.
I think that's been a wonderful exposition, Dr. Shankar. I think it's probably a trick that you need to keep in mind when you have fractures like that. Have you done these in many a times we see similar fractures or even worse in elderly patients, more comminution, more this thing. Do you or have a good number of cases in that age group as well?
Yes. In fact, that young lady, you won't believe the pathetic bone quality of that youngster. She was barely 20 years, but the bone felt like as if we were operating on an 85-year-old. It was pathetic bone quality, and yet this is the one with the comminuted column on one side held with lag screws. So that girl did really well. I think the only point here is that although her bone to start off with was very osteoporotic, the young age probably was enough fuel in the engine to get the fracture past the healing point, although it was held just with these wires and tension band systems in place. I completely agree with your anxiety about having two tension bands in place with comminution on the columns. But the point is that even in your osteoporotic patients with an olecranon fracture, there are so many of these with tension bands that do amazingly well. So, and of course, you mobilize them very, very early. So there wouldn't be any specific reason for us to not use a tension band when we have bone-on-bone contact on that column. That would be my submission.
Shankar, I have one question.
Yes, sir. Chandrasekhar, sir.
Okay. I agree. I think I welcome your tension band wiring of comminuted fracture of lower end humerus. When you are going to mobilize the patients, your elbow movements, what day you are going to mobilize the joint?
Yes, sir. So I think I showed you 3 of them there. So okay. The lady who had the shaft with the distal humerus, that person we mobilized very early. I think it was on the 3rd or 4th post-op day. The moment her soft tissue settled down, we were happy with things. We started mobilizing early because that fixation was rock solid stable. The girl who had double tension band on both sides with comminution in the column that was held with a couple of lag screws, I waited for 3 weeks so that I know that there's enough of soft tissue, hold and recover there for me to proceed with some amount of comfort and a degree of, my own confidence. But I don't think waiting for 3 weeks actually makes a big difference as far as bone healing goes. But it was just a sort of, for my own confidence, I waited for 3 weeks and then started. So yes, sir, it is dependent on the stability that we've achieved on table. I think that's something that I definitely would echo what Professor Fernandez pointed out.
Okay. With the literature, what the literature says, and with our own experience, say you had to fix the lower end of humerus or any fracture around the joint immediately with a good stable fixation and mobilize as early as possible, even a next day. Otherwise, all the joints are notorious to go for stiffness. We all face those problems. So one is the tension band wiring on the uncomminuted fracture lower end of humerus. Do you think or really they are so stabilized fixation to mobilize the joint so early?
Chandrasekhar, sir, I think the point is that these are not instead of the regular plates and screws.
Sir, shall I interrupt here? I think we leave this question to answer for Professor Fernandez. Professor Fernandez, you are the pioneer, and we would like, or the audience would like, your take-home comments on the role of tension band in elbow fractures.
Well, first of all, the principle of tension band wiring is, first of all, that it works in the tension side of the extremity. So when we were talking about fixation of shaft fractures of the humerus, we thought that the tension band surface was posterior, because most of the, when you flex the elbow, you have much more tension forces on the posterior side. But when you lift an object like that, the tension side is on the front. So the whole concept of the tension band principle that should work on the tension surface of the bone, as for the olecranon and for the patella, which is classic, the most thing there, if you have the other prerequisite, is to have absolute good contact of the opposite cortex. And in Dr. Shankar's presentation, it is a little bit, it doesn't follow the classic teachings of the tension band, but it's a very stable construct. So I think with a double tension band wires on both columns, we increase the mechanical structure of the whole distal humerus, because you see those things are covering and actually producing tension on the surface and compression on the inner side. The other thing is one diagram you showed, Shankar, of that author that passes both K-wires across the surface of the cortical bone, and the wire goes around the tips. You saw that?
Yes. You want me to put that up again? I can put that up for you.
That is very important, because
can I put that up for you, Prof?
Sure. When you show that, I've used that in the hand, and when I use a lot of tension band wiring in phalanxes or in metacarpals, that trick is very good, because it holds the wire and it won't pull out or break the very thin cortex of osteoporotic bone. There's one that, it's a little bit, that one, yeah. You see,
yes. And as well as this.
Yeah, that one. Instead of passing it through a bone hole that would perhaps create a fracture or create a fissure, fissurate the bone, this is a very good trick. And I don't know what the difference is biomechanically of that pulling it around the tip or through the bore hole. I think if you have very good bone quality, like in your young patients you showed, it doesn't make a difference. I have used the tension band wire technique for a unilateral column or for avulsion fractures, which is a classic indication. Avulsion fractures, the lateral medial epicondyle. Usually they come together with the anterior frontal coronal shearing fractures.
I have a question, sir.
Satish.
Can I ask one question?
Yeah, go ahead.
In the olden days,
last question.
In the olden days, we used to fix this comminuted fractures with 1/3 tubular plate, 2 of them. And then we used to say in this heavyweight people, the implant is to fail. Then we ended up putting, we should put a DCP or something. We felt that 1/3 tubular plate is too weak to hold in a heavyweight person. If that is so, this K-wire also should break. My question is, in the olden days, we used to put 1/3 tubular plate, right and left, medial and lateral. And in heavyweight people, many times the implant is to fail in comminuted fractures. So looking at that, this K-wire, can it take the load?
Professor Fernandez, can you take that question, please?
Yes, the implants, as is for a very big patient, if you have to adapt the size of the implant to the size of the patient, you can use a very thin third tubular plate for a very big skeleton, So he said that you could use a DC plate, but those plates were very difficult to bend. You could put a DC 3.5 DC plate at that time before we had the combi holes and the locking plates that came after. So the step in between was to use the reconstruction plates that were very easy to bend and very flexible, like for the clavicle and for the pelvis. That was a step forward. And then when they did the locking feature, that's already a very a step forward. I think that probably tension band wiring, you can also increase the rigidity of the tension band by using thicker K wires and thicker wires, or putting a double wire loop, as I showed for the electrical. If you increase, I think you would increase the rigidity of a tension band wiring for a big bone. But instead of using 1.6 K wires, you can use 2.0 K wires and a little bit thicker wire, or better perhaps.
What
we need to bear in mind is these are few selected fracture patterns that you're utilizing this, Dr. Satish. It's not for, where you can get enough purchase with schools, you do that. But otherwise, I think this is a very good question. I think with that, we'll move on to the next presentation by Professor Fernandez. I think it's on regular fracture.
हम लोग तो 10 बार तो नहीं आया, हम लोग 10 बार तो नहीं आया.
You see the slides?
Not yet, sir.
Not yet.
डॉक्टर आप बोल रहे हैं, आप आसानी से बोल रहे 3,000 रुपये, मगर हमारे पास तो होना चाहिए ना डॉक्टर. मगर आपने डॉक्टर आपने क्या जबान से बोले थे कि इसके बाद में परमानेंट.
Now?
Yes. Yes.
आपका बात सुन के हम लोग ने जीत पे लगा दिया ना डॉक्टर. सब जगह घुमाए ऐसा थोड़ी.
Okay, in this second presentation, I will talk about the controversial issue about the using internal fixation or radial head arthroplasty for radial head fractures, Mason type 3. So the type 3 radial head fractures, the decision-making that we have is the fracture number and size, the displacement, the articular surface condition, whether or not you have degenerative changes, age, bone quality, and associated ligamentous injury or elbow fractures. So these are all the parameters for the decision-making. You all remember the Mason classification with the type 1 minimally or non-displaced, type 2 displaced more than 2 millimeters or angulated neck, and the type 3 is a comminuted or multifragmentary fracture or with a very displaced fracture of the neck. Hodgkin's modification added the type 4, which is actually the fracture of the radial head associated with posterior dislocation. And in this group from John Stanley, this is a prognostic classification which starts undisplaced to displaced with increasing severity of the fracture pattern and convolution. We all know that the Mason type 2, which is actually a shearing fracture of a two-part fracture, very easily reducible, as you can see here, and they do very well with a screw fixation alone, because it's a partial fracture of the joint surface. For the type 3, at that time, at the beginning, internal fixation was only recommended for a fracture that not more than 3 fragments or the displaced fracture of the neck, as you can see there in the bottom of the slide. Here, for example, we have a Mason type 3 with 3 fragments. Patient has a fracture dislocation. Here you see the displaced fragment that remained in place. And this drawing shows what we found during the operation. Actually, we have three big fragments, and this can be treated with screw fixation alone with a good result. Here we have now a more complex one, already 3 fractures in the joint. That would be a 4-part fracture, better said. And again, in those cases, you might need to fix them with an additional special design plates for the radial head. But these may produce the follow-up. Usually they might have impingement. You might have to remove the plates early. And here you have a very good result. This is a Mason type 3. I don't have the CT scans, but it had 5 articular fragments. And you can see here. So this is already, when you see this, when you open and you see this amount of comminution, it's very difficult to think that you might fix them. Some authors in the German school, they have taken everything out to the operating table, fixed the plate inside and put it back in as a prosthesis. And you would think, well, what about the vascularity? Do these things end up with an avascular necrosis or not? And amazingly enough, they revascularize, but probably not all of them. So here is the controversial issue. How much do we accept? In this case, the patient did very well. You see an additional fixation of the lateral collateral ligament with good final results. So the current recommendation, I would say, is the Mason 2 and 3 fractures through a lateral extensor tender split incision or a Kocher approach, no more than 3 fragments. Remember to fix these in the safe zone to avoid impingement of, or if you can use also screws alone, use headless screws and low profile special plates. If you have associated instability, you have to do the repair of the ligament. What are the complications? We have found inadequate fixation, hardware malposition, injury to the posterior interosseous nerve, inadequate reduction, articular incongruency, delayed union, non-union, and implant failure. As you see, the list is quite big. And the late complications, as I said before, hardware impingement, elbow stiffness, necrosis of the fragments. You may need to remove metal, loss of extension, and post-traumatic arthrosis. So here's a typical case, has been badly treated. This is a lousy surgery, and you can see that they have secondary displacement. You don't have very good purchase of the articular fragments, and this ended up in a vascular necrosis and articular incongruity. This was salvaged with a bipolar cemented stem Judet prosthesis. Here you have a patient with residual pain, limited motion, painful pronation and supination, and with a crepitus. You can hear that something was scratching there. When we opened it, we found that broken drill bit was eroding the sigmoid notch of the ulna. And this was, again, salvaged with a bipolar prosthesis, and here with a good result at 4 years post-op. What about the evidence of the literature review? This is one of the original papers by Ring and Jupiter and Quintero, 73 patients with internal fixation of the radial head, and they had a 10% overall incidence of non-union. And then the Mason 3 B-type that increased to 25%. And at that time, they already said that the radial head prosthesis would be the best solution to prevent complications such as vascular necrosis and non-union. However, in the last 20 years, we have seen a rising popularity of internal fixation. Basically, because we have improved implants for this special anatomic area, as well as, for example, the coronoid fractures, and also the surgical skills. Most of the residents now, they go to cadaver labs and they train specially all the small little tricks of this internal fixation of small bones, but still is technically demanding. This paper by Japan in 2003, the 10 patients treated using low profile mini plates. You can see that out of 10 patients, all had healed, but they had 9 plate removals out of 10 patients, meaning that probably the plates are it comes to a point where they have actually an impingement with a sigmoid nerve. In this one, they compared 13 patients of internal fixation against excision, which is also, we haven't discussed excision as an option of the treatment, but they had actually improved strength in the internal fixation. If you see this paper coming out of Germany in 2013, they did a study of 851 clinical studies, and 58 were included for review. And this means 1,264 patients. And look at the results. Mason 2, best option for internal fixation. Overall rate of success, 98%. Mason type 3, that doesn't describe how many fragments you have in the type 3, but they had 92% success with internal fixation. Better than resection and better than replacement. And the Mason type 4, remember those associated with elbow dislocation, better result with internal fixation, then followed by replacement as a second place. For these authors, the decision-making for radial head prosthesis is made intraoperatively when you realize that you have good stable fixation. If you cannot achieve that, then you might decide to go for an insertion of that prosthesis. So the current indications now for arthroplasty are the Mason 3 and 4 fractures that involve more than 1/3 of the articular surface, and they're very difficult to fix. Or in those cases where you have associated ligamentous injury. For example, a unhappy triad where perhaps you want to start to move them early and better to have a stable radial head with a prosthesis than a comminuted fracture that first has to heal. So associated Essex Lopresti injuries, elbow fracture dislocation, terrible triad, radial head excision, post-traumatic arthrosis, and degenerative joint disease would be the current recommendation. A couple of examples. Here you have a fracture that was reduced, a fracture dislocation. This is the X-ray following reduction. You have a Mason 3, very displaced neck fracture with a coronary fracture. So we decided to treat it with a prosthesis and fixation of the coronoid, a little bit atypical coming in from distal to proximal. The patient had a very good residual function. Here you have another one, elbow fracture dislocation with a very displaced radial head, as you can see here. And here you have an avulsion of the medial collateral ligament, bony avulsion, so an unstable. Here she had a redisplacement in plaster because it wasn't fixed over 90 degrees, posterior medial instability. So this one we treated with a medial repair, radial head replacement, and a static fixator for 5 weeks. And everybody would tell me, yes, what about elbow stiffness and topic ossification if you don't move them? I don't think it's a problem. We took the fixator out at 6 weeks, no, 5 weeks actually. These were the x-rays. And look at the function that this patient has at 5 months. Good. You could also tell me, yes, but it's just an anecdote. It could be. But there are other ways of mobilizing now with the internal dynamic stabilizer. Like you see in this case, a terrible triad, posterior dislocation, radial head fracture, comminuted, and coronoid fracture. So usually you have to repair the ligaments, the radial head repair, the coronoid fixation for the type 2 and 3 of Morey's classification, where you have a big, irregular, very good sizable fragment. So this one, a radial head prosthesis was done, medial repair, and a dynamic internal fixation was used. And this one has a pin, actually a bolt that goes into the rotation axis of the distal humerus and is fixed with a little system with a small plate over the electron. In this one, you can actually mobilize. This was devised by Dr. George Orbe in Miami. So this implant, which is actually under the skin, as you can see it there, you can take it out after 8 to 10 weeks post-op. And so therefore, I think this implant, it's much less cumbersome than using a hinge fixator with all these pins going across and trying to find the exact axis of rotation. So what about the evidence with the prosthesis? This is a paper who looked at 12 cases of the Jude bipolar prosthesis. They had good and excellent results in 92% of the patients with prosthesis compared to 12% of the internal fixation group. In this other paper, 67 patients with Mason type 3 radial fractures, you see that the complication rates with radial head replacement was less than the internal fixation group, and then also the satisfaction, patient satisfaction rates was higher in the radial head prosthesis. This one has looked in 2016, 138 cases of internal fixation and 181 of radial head arthroplasty. It's a meta-analysis, and the conclusions were that the radial head arthroplasty is a better outcome than internal fixation, but the long-term studies will be required to realize whether or not the complications of radial head arthroplasty are problematic. This is another one that came out in 2011 with 45 patients with unstable multifragment fractures of the radial head. And again, the radial head replacement had a better favorable joint function than internal fixation. So we can see that in the current literature for Mason type 3 fractures, there's still a controversy regarding whether or not which is the optimal treatment. And what about failure of metal radial prosthesis? This paper coming out of the Mayo Clinic, they removed the prosthesis in 47 patients for a variety of reasons, but the painful loosening was the most common cause. And the other thing was the overstuffing of the or over lengthening of the radius that caused erosion, as you can see in the slide there, that now the capitellum it's concave instead of convex. So in conclusion, the current evidence supports that open reduction internal fixation for the Mason 2 fractures and Mason 3 fractures with 3 articular fractures. For multifragment fractures, controversy still exists whether or not which is the optimal treatment. Innovative current technical refinements have shown improved outcomes with internal fixation, as I showed you in the multi-center study from Germany. However, studies have shown good to excellent results with radial head replacement with 3 or more fragments, but longer-term studies are required to prove whether or not the initial benefits of radial head arthroplasty will be offset by late complications. Thank you very much for it.
Professor Fernandez, that was a brilliant presentation, but it still leaves us confused as to what is the best way out. So if there is a complication rate of 15% under your hands as a pioneer, what about people who have still to master that art of radial head replacement? That would be one question. Second, what are the results of radial head resection, which we have been doing since time immemorial, and nobody has come back to us with any issue?
I can show you a slide on that. So first question is, I think that with the new implants and the new skills, we're getting much better fixation of the comminuted radial head. The danger of a vascular necrosis that everybody said, yes, the too much fragments, that's a terminal vascularity going in, like in the scaphoid or in the femoral head. I think if you have stable fixation with the plates to the shaft, there is a revascularization going on in these fractures. I think that results have been improved now with internal fixation, as I show you in the paper coming out from Germany. If things go wrong, you can always put a prosthesis later, or you can do a resection. You see, I have done some salvage surgery. If a prosthesis gets loose and you haven't resected too much, what I've used is to do a flap of the ankylosing, muscular flap to interpose that. But you have a problem. You might have proximal migration of the radius, especially in heavy manual workers, and then you have a ulnar impingement distally, which you might treat with an ulnar shorten. But it's always an escalation of operation. So I think if you feel comfortable and you have the special small little implants to fix the comminuted fracture, you might try it. If you don't feel comfortable, it's better to do a replacement in the first place. So that would be my philosophy. But you have to have both the implants and the prosthesis. And I think that not in every country in the world we are that they have everything, for you to use in the OR. So if you see, we don't have any implants, so what do? You do a resection. But I remember at that time when the Celastic prosthesis came, remember that from Swanson? The first radial head was a Celastic implant. And we used to put it in as a spacer in the unstable elbow. And we knew that it did silicone synovitis and everything. So you removed the prosthesis later when the elbow was already stable. You see? The other thing that some people have done is for salvage surgery, it's like an inverted Soveka-Panji. Like you screw the head to the sigmoid notch and you create an onion below. I don't remember the author, but I've done that a couple of cases.
Thanks, Professor.
Professor, I have a question. What is the longevity of the radial head process? How long will it last in a young patient?
Well, you see, the problem is that all the papers you do, literature review, we don't have long-term results. You know that you have I didn't show all the slides I've got on literature because of the 15 minutes I had, but there is 16 cases, 10 cases, 1 year results, 2 years, maximum 4 years. So the case I showed you, that young girl that had the drill in, it's my case. I lost her to follow up at 5 years. So I can't tell if they did well or not, or how long do they last. The one I showed you from Dr. Orbe, that case with the internal fixator, his prosthesis is a monoblock, but actually gets the real angle, the valgus angle in the head for each patient specifically for the anatomy. So it's a anatomic prosthesis and has a longer stem than all the other ones. So it probably could be, but I haven't seen long-term studies of these prostheses. Perhaps you can ask Professor KRETTEK afterwards what he thinks.
Do you have any questions on the panel, or should we go for the case discussion?
Sir, what is your experience with the partial radial head excision?
Partial?
Yeah.
What do you mean? You take the fragment out and leave the rest around, or what?
Yeah.
No, I haven't done that. I mean, I do a complete head resection and I put a prosthesis in. If I do a resection and I put a flap of the ankylosing inside the hole, and I try to close the capsule and have like a biological, vascularized muscle flap space. But I tell the patient if it's a hard worker, they might get radial impingement. But you can always treat it late. but I haven't done partial excisions.
Do you see any radial head fractures with SX lubricity? How do you diagnose it and drop? And do you do something more like a intraosseous reconstruction?
Could you repeat the question, please?
Professor, with the radial head fractures, do you see a SX lubricity injuries as well?
Yes.
How do you assess it intra-op? And what do you do if you diagnose it intra-op? Do you do a intraosseous reconstruction?
No, I haven't done that, but the way to do it now, there is some support in the literature that you should replace the radial head, repair the triangular fibrocartilage ligament, and at least you can put a tight cord, because in the acute situation, the central band, which is you can't sew it up together, but you can put a tight rope, that implant, tight rope between so you can use it as a temporary measure until the central band heals. And then otherwise, there are a lot of reconstructions done by Osterman. They use patellar tendon. They've used pronator teres, flap, things like that. But I don't have any experience. The ones I've done, there have been always late cases, and they come with a forearm contracture. So you have to release the interosseous membrane because they can't pronate and supinate. So what I've done in those is I've reconstructed the radial head and did a shortening osteotomy, but usually they have ulnar plus. Shortening osteotomy, release the whole interosseous membrane and put a prosthesis in, and then in those chronic cases you get perhaps 50% of forearm rotation back. But in the acute situation, there are people that have put in the tight rope to hold the longitudinal instability.
Okay. Dr. Ajit, do you have any questions from the panel, or should we go for the case discussion?
I think we should go for the case discussion now because it will be later.
Dr. Purushotham, you can share your screen.
Yeah, sure.
We're strict only to the case and not to the theory behind. Hello? Please stick only to your case.
Sir, I didn't get you.
No theory behind, just the case discussion.
No. Only regarding the case.
Yeah, exactly.
Okay. Thank you everyone for giving me this opportunity. I'll be presenting two cases just for the case discussion purpose. So first case is a case of neglected elbow fracture. Neglected elbow fractures represent an uncommon entity in the West. However, they remain frequent in the countries. The reason are use of traditional treatment, which is still frequent, remote areas, and poor access to the treatment. Patients are often neglected and not treated before being seen by a specialist, and I'm here presenting one such case. So the 40-year-old male farmer by profession came to us with complaints of restricted movements of left elbow. He had a history of RTA 4 months back, which he had sustained in a road traffic accident, and he was treated by native treatment and the local splint was applied. After 2 weeks, the patient himself removed the splint and started his routine activities. So when we see the video, this was the initial presentation. He had very limited range of movement at the elbow, and there was significant varus and valgus instability was present. So when we looked at his X-ray at the initial presentation, in the anterior view, you can see that capitulum looks united to the distal humerus, properly malunited, and the trochlea looks displaced along with subluxation of the radial head. In the CT, the capitulum doesn't look united, but the trochlear displacement is seen along with subluxation of the radial head. when we took the CT scan, there was no arthrosis or arthritic changes which was seen in the CT views. So we thought, with the consent of the patient, we went ahead and tried to fix this fragment.
Sir, just hold on here. You please throw open this question to the panel. What the panel will do?
Yeah, sure, sir. Sure.
Yeah, you don't tell everything.
Yes,
ask the panel.
Yes.
We have a very distinguished panel. Ask one by one what they will do for this.
Can anybody take up what you want to do with this?
Yes, correct. Anybody from the panel, please come up. Ajit, Ajit
Mundewadi speaking.
Yeah. What will you do?
We see a lot of cases which come late after 4 weeks, 6 weeks. So we approach elbow posteriorly through Campbell's approach. To osteotomy, we do try to reconstruct. Maybe not complete anatomical, but trochlea and capitulum are assembled and stabilized by the lag screw and then fixed to the column. Even in some cases, 3 to 4 weeks later, we are able to reconstruct to some extent and not be anatomical reduction. Still, we get fairly good movements. I think still we can attempt.
So in short, you are saying that you treat it as an osteosynthesis.
Osteosynthesis, yes.
Yeah. Okay, fine. Anybody else take that call? Ajit?
Yeah, I think most of us would go for attempting osteosynthesis here. The only thing is, when you freshen the fracture site, there will be some sort of a scalloped bone there. So you need to fill that up with bone graft, get your length, and then stabilize it. It looks like a very low fracture, and getting a purchase with implants, standard implants, is going to be tricky.
Yes.
So that will be a decision that you need to plan out well and decide on table. I think probably for the capitulum, you will be needing some sort of headless screws. I'm not sure. That again, can we go back on your CT to that 3D thing? 3D
just
cuts?
a second, sir.
Yeah.
Yes.
So yeah, maybe you'll get screws here, not headless screws. You may get proper screws. It's more of the lateral condyle rather than capitulum per se, I think. So that you will get. The thing is, we need to decide on the approach as well. You will need an osteotomy, like Dr. Mundewadi said, and then you need to put that back. You need to be prepared for bone graft and some probably, I'm not sure again how good a plate you will be able to get onto that. Is a very low transcondylar. But I think if you put a adequate graft, then on the medial side, you can get a good plate. And on the lateral side, couple of screws, making sure that the intercondylar region is also addressed.
Good. We throw open this question to Professor Fernandez. If Professor KRETTEK has joined, he can also answer this call.
Yeah, I agree. I agree with what has been said. Olecranon posterior approach, and then mobilize the non-union side or the delayed union side, resect all the, and probably you should release a little bit. If you have a capsular contracture, release the capsule through the plane. I don't think if it's difficult to get length, you might use temporarily a fixator between the ulna and the distal humerus.
Sir, do you consider a primary repair of the ligaments in this patient?
No. I think the first thing you have to get is reconstruction of the skeleton.
After the reconstruction, would you consider the repair of the ligaments as well?
No, I don't think so, because I think just because of the fracture, why do you think that the ligaments have to be...
Ligaments, we have to see only after opening it up.
After opening, the amount of valgus virus instability...
No, that is because of the fracture itself.
No, I agree, but that's what that is. This is the teaching exercise. No, there are so many other people listening.
The patient has complete extension, but cannot flex. So I don't know if just by doing the olecranon osteotomy, you have a release of the soft tissues posteriorly. And then you will get the flexion back. And since the guy has complete extension, I don't think there's a lot of capsular contracture. And then the question of fixation, I agree with the graft if you have a bone defect. And I think that the trochlea fracture, the trochlea is intact and the capitellum has a split.
Yes.
Split. So I agree with a lateral fixation, medial fixation with a plate. Dr. Jupiter had, before that you have the reconstruction plates, you move the ulnar nerve out of the way after the cubital tunnel, and you can do a wrap-around plate. He used to take a reconstruction and wrap around the medial, and you have an extra hole that you can send a very long screw to the opposite cortex. If you don't have, for example, available new modern locking plates. And on the lateral side, either screws or tension band wiring would be great on that side. I think we have had a great presentation on the tension band wiring.
Yes, sir. What did you do?
The challenges were like the panel.
Don't tell us the challenges. What did you do?
No, we went ahead posteriorly through the midline approach.
Yeah, can you show that?
Sorry, we don't have in-top pictures.
Okay.
So, and we fixed 2 plates after doing the chevron osteotomy. We did face a lot of problems because there was a lot of osteopenic fragments because of not using the elbow for a long time. There were considerable osteoporosis. It was difficult to handle the fragments. So this is what I could get after fixing the fragments using both the plates.
Got any better quality X-rays?
No, sir. This was done in a local setup, government hospital. So
post-op result or anything like that, or
no, I'll come to that. Okay. So when you see the second month post-operative pictures, you can see that there is screw back out from the capitellum, and the capitellum has displaced anteriorly, probably because of less hold at the capitellar site. The fragment has moved anteriorly. And when we looked at this range of movement, this is at the second month, and we didn't try to manipulate the range of movement on table because we were afraid we will lose the fixation because it was so osteoporotic because of the, it was very difficult for us to do a manipulation. So this is the range of movement we got at second post-operative month.
Very good, very good.
Then this is after 6 months. So when we look at the X-ray after 6 months, still the capitellum is anterior, but somehow the fracture is united. Still there is, you can see clearly that there is backing of the screws posteriorly. And this is the final follow-up after 1 year. He's got about 20 degree to around 120 degree range of movement of the elbow.
Sir, I think that's a good job done. Under the circumstances.
But you can see, sir, because of the screws are backed up posteriorly, but somehow everything fixed. I want panelists to comment what we could have done differently.
No, I think
capitellum, it was very difficult.
Professor Fernandez has already agreed that you have done a very good job, and we will leave it there. Sir, thank you very much. I don't think we have time for your second case.
Sure,
so we will request Professor KRETTEK to take over.
Okay, thank you.
He is already, yeah. Vamsi, ask Professor KRETTEK to join.
Yeah, Professor KRETTEK has joined.
Yeah, Prof. KRETTEK, I think you can go ahead, Prof. KRETTEK, you can share your screen and go with your presentation, Professor. Yes, yeah.
Good afternoon, everybody. Just let me go quickly into presentation mode. And I really appreciate this invitation and congratulations to the organizers for putting together such a very stimulating and wonderful program mixed up with complex case studies. I'm very happy to share with you some of our thoughts on management of elbow fractures in the post-fracture period. And there is no conflict of interest for a couple of paid editorial tasks. And we will look into different pathologies which come up after complex elbow trauma, like stiffness, instability, implant failure, non-union, and specific aspects of defect.
Professor, sorry to interrupt. I think we need to change the slideshow differently. We're seeing a presenter view. We need to put it to the full screen view.
You can see only, what can you see?
We can see the presenter's view. We're not able to see the single slide in the complete screen.
Full screen you needs to go, I think.
Yeah.
This is better?
Yeah, now it's better. Yes, Professor. Yes,
okay,
thank you.
Sorry. So we all know these fractures can cause a lot of problems, pain, limited range of motion, problem with union, and infection. And I have put together a couple of cases. This will be a case-based presentation. And the first case to start is a case where I think fixation problems become very obvious. This Utah is an almost 70-year-old diabetic patient after a fall. We see the olecranon fracture with an intermediate fragment. And on the right side, we see the postoperative pictures. And in many of these cases, I'm always wondering, there is a huge amount of screw in the proximal main fragment, but the fixation of the most crucial fragment, where the pull of the triceps is challenging, its fixation is always very limited. And the postoperative film shows a few weeks after initial surgery, the fragment is obviously moving out of this fixation, and even more when we have a look on the soft tissue of the patients, we see a soft tissue defect as well. And we have the problems that we have joint stiffness, chronic infection, and a dislocated non-union. And the question is, what are the options in these sort of patients? So we spoke with the patient, brought her to theater and debrided her. We removed the plate, inserted antibiotic cement bead pouch, and 2 weeks after we brought her to theater for a re-osteosynthesis, again with an elbow plate, and the intention was to fix the proximal main fragment with a large screw to have better hold into this short fragment. Question is, are these 3 screws in the proximal fragment sufficient? Is everything good? No, it isn't. And another week later, she again has a dislocation of her proximal main fragment due to the pull of the triceps tendon. So the question is, what are the options here? In this case, diabetic patients, non-union, previous infection, pull of the triceps tendon. And I would like to share with you for discussion a solution we did here. I have a little video clip from the surgery, the surgical steps. We removed the proximal screws. We left the distal screws because we can still manage the situations. We did a tenodesis of the triceps tendons. The proximal fragment was unperfused and there was additional bone defect. And I think she needs she needs a fixation which addresses the pull of the triceps. And I think very resistant against pull is always a cerclage. Screws are not good resistant against pull, but cerclage wires are. We add some BMP to the fracture zones, and then later on we will add after reduction, we will add the cerclage wires in 2 layers, and then we do gradually compression with the help of the reduction forceps, one on the radial side, one on the ulnar side, and then we tighten carefully the cerclage wire on the ulnar side and the radial side step by step. So we have an equal compression on both sides and a uniform compression at the fracture zone. So we go step by step, medial to lateral and lateral to medial until we get the uniform compression. Here we see the double layer cerclage wires, and here's the postoperative films. We see the 2 cerclage wires, one more to the joint, one more distant to the joint, with a ring where we tighten them, and this uniform compression obviously led to healing within the next 8 months. Here is the postoperative CT scan 9 months after revision, and we see in yellow that it's a course of the cerclage wires, one more proximal closer to the joint, one more distal, creating this uniform compression and neutralizing the strong pull of the triceps muscles, and also the range of motion. Not too bad for this type of history the patient had before. So another thing I would like to share with you is a case of a 62-year-old patient who came as a referral for arthroplasty. And we looked at the pictures and we saw this distal low fracture of the distal humerus, comminuted in all compartments and with a dislocated capitulum radial of the radial side. So we thought arthroplasty is probably too much and brought her to theater for osteosynthesis after reductions. The synthesis is very impacted, and we need good visibility of the joint. We did a olectron on osteotomy. We think it's always very important to keep the proximal articular cartilage bearing fragment moist in order to protect the cartilage. Then we add a reduction clamp to the distal main fragment, and this allows us to pull out the olecranon. And now we have a good insight into the articular surface once we have pulled on the joint, and even more than 180 degrees. Reduction of the fracture with the help of the chisel and the laminar spreader, gross reduction, and then temporary fixation with the K-wire, and a biplanar locking plate fixation of the ulnar-sided construct. We believe that these small fragment clamps are always helpful. We do distal fixation first, and then we pull with the help of the reduction clamp. We pull it to the proximal direction in order to get some sort of a compression. And once we have achieved this, we do add a locking screw in order to hold the compression and to maintain stability. Additional double differential screws on the in the articular surface, because there's not much space to add implants, and the reduction of the radial column is more or less, because it's so mushy, is more or less kept with the 2D screw and the molding of the construct. Here's the postoperative films. plain films and the CT scans, we see that we have achieved good reduction and alignment. The osteotomy is properly reduced and fixed. And here, as a patient is 8 months post-operatively with good healing, but we have still left a problem, which is a limited range of motion. And this is a good example because I believe strongly that we, in these cases, we cannot achieve both at the same time fracture union and a perfect range of motion. So the clear priority in these cases is healing first and range of motion secondarily. And in a second operation, we did a partial implant removal, and then we do anterior capsulectomy in order to get a better range of motion for flexion and extension. Here's the intraoperative range of motion, postoperative range of motion, and this is a 13-year follow-up. So very happy patient, very happy that she didn't get an elbow arthroplasty and got the reconstruction, had a not optimal range of motion in the first step, but second step was arthrolysis. Here we have another problem, which is not a rare problem. We have a large articular defect in the posterior part. The patient comes from Berlin. The surgeons there told her, you have to live with it, and it may be filled by itself, but over the time it became more and more symptomatic. So we created a treatment plan which consisted of a graft from the iliac crest which had the same shape as the curvature of the articular surface. Here's a defect, and this is filled with a similar curved autograft from the iliac crest. This was fixed with press fit and some mini screws from the handset. And after ingrowth of bone, we brought him back to theater and added some chondrocyte, tissue-engineered chondrocyte, which we took out in a separate surgery. And after 4 weeks of tissue engineering in the lab and multiplication of the cells, this was covered with a resorbable membrane. And this is a result after 11 years. We have an 11-year follow-up, no pain anymore, full recovered, including push-up. Very, very happy patient. But when the defects get larger, the simple solutions, like in this case, are not sufficient enough. Like in this patient from the Kosovo war, he had a high energy gunshot injury, and he presents with a stiff chronic MRSA infected elbow, significant pain, and almost no function at all. So we brought him to theater. We did a thorough debridement and soft tissue release and antibiotic cement spacer, resulting in a large osseous defect. We did several redebridements until we finally had a clean situation, and then a tumor prosthesis in combination with a free latissimus dorsi free flap was a part of the solution. In these cases, almost always you need a free flap. Here's the treatment course with the ingrowth of the latissimus flap, and here fast return functionality, low and reasonably good increase in functionality of this patient. Not perfect, but compared to what he had before, significant improvement of functionality and decrease of pain. Sometimes these defects are not as large as the case we saw before. This is a patient with also an open distal humerus fracture. He had complex fracture dislocation, and the central part of his distal humerus, the articular central part, was missing. Here it is filled with an antibiotic bead, cemented piece, and the CT reconstruction shows we have an ulnar side, which has a partial joint surface. We have a capitulum, a radial capitulum left, and we have a large central trochlear defect. So the question is, what should we do with this patient? O3B fracture, 40-something-year-old, and his dominant hand. So we thought this is not damaged enough to get a fully hinged prosthesis, and also would not be appropriate to give him an arthrodesis or anything like that. We thought this might be a good case where we could do a 3D analysis compared with the contralateral side, get a 3D printed implant, which is just as a negative part of his joint defect, and combine it with a plate in order to fix it to the proximal shaft. Here, some of our drawings and 3D demonstrations of the planning phase. And here is a negative form of the missing bone in the central parts of the joint. And this is combined with a little plate stump in order to fix the construct to the humeral shaft. This would be the situation after reduction in this 3D planning program. And here's the postoperative film with where we see that we have good fit of the 3D planned implant in relation to the remaining bone. Here's the postoperative film, 11 months follow-up. We have some ossifications. The patient has a stable elbow. And most important is the functionality. That's the patient in his forearm rotation. The fracture is on the left side. And we see that we have some limited range of motion for flexion, but patient is still making some progress, some 25 degree of extension gap, and some amount of flexion, deferred flexion missing. But no pain medication. He's reaching his mouth and can feed himself back to work. So 3D analysis actually is pretty helpful in these cases, and has an increasing role in our analysis and planning. Here's such an example of a restricted forearm prosupination in a patient with a malunited forearm fracture. The patient is limited in his supination, where we see the bone is getting in contact before he is reaching the full supination. And when we look on the distal radio-ulnar joint, we see that's in full pronation, as a patient would result in dislocation of the distal radio-ulnar joint, which presents him from adequate pronation. So planning. Also, the healthy side is very important in order to get the information, the geometric, steric information we need in order to get a proper physiologic range of motion in the forearm. And then we superimpose the healthy side with the injured side. The injured side is yellow, the healthy side is gray, and we see significant differences. And these differences help us in the 3D planning for a surgical solution. We have to do osteotomies. We have to change the bone position. We have to do some mini lengthening and shifting and a slight rotation in order to get the best fit in order to achieve natural forearm rotation again. So 3D analysis getting more and more helpful and supportive in our understanding and planning in the treatment of restricted forearm motion. We call it 4D analysis because it's 3D over time. And sometimes we have a combination of problems. We have the geometric deformity problems, and we have articular surface destruction. And I would like to share with you the case of Katrin. Katrin is a 24-year-old young female, and she had a neglected radial head fracture dislocation, as you see here. She had a failed extending corrective osteotomy, and therefore she had within this context, she had a chronic anterior radial head dislocation. The radial head is not only dislocated, it also deformed. The condyle, the radial condyle is deformed and shows a defect. She is unstable on the radial side. She has a deformity. She has limited range of motion, but most important of all, she has significant amount of pain with an VAS of 6 to 8. So we thought in order to salvage her joint, this would be a case for elbow transplant, transplanting the units between radial head and ulna, the articular surface of the ulna, together with the ring annular ligament, lateral, collateral ligament, and a bone chip in order to be able to fix it. And on the radial condyle, we would go for a radial condyle transplant as well from a multi-organ donor. So we see here the donor side joint. And I would like to share with you the video of the case. You see the significantly destructed radial head. There is no annular ligament. And when you compare it with the nice pathoanatomy of a functioning elbow joint of the transplant. So here a small chip from the ulnar side with the joint is made, but the crucial step is the radial head perfused or not? We see the dots of blood coming out of the tip. So we continue, we resurface the radial condyle, we empty out until a short shell of the radial head, make sure everything is moist all the time, but still everything very unstable because we have no annular ligament attached yet. But once we pull up the context of the annular ligament, this is getting very, very stable. We have the little bone chip, which is attached to the proximal humerus, and now we have a functioning unit. Here's the postoperative films. We see the large deformity we had before is gone. We have a straight elbow. Again, we have a nicely centered radial head, and this is true in both plane. And here the CT and the radiographic information of the good bony ingrowth of the radial head at the follow-up after 2 years. So we have some improved range of motion. We have the 0, 30, 120 degree for extension, elbow extension and flexion. We have 60, 0, 50 for prosupination. And the pain is not 0, but it's significantly decreased to a VAS to 2 or 3, coming from 6 to 7. And she's back to work again, a 24-year-old young patient. So let me summarize the management of complex post-fracture situation in the elbow. Olecranon non-union, I think it's very important to neutralize dislocating forces, to understand the dislocating forceps. Triceps tenodesis might help to prevent from pull. But I think also very interesting is this two-level compression circlage techniques against pull out. It's much better than screws. And we need to be restricted with physiotherapy until we have the healing first. Low fractures, very important. Healing first. Don't get nervous. No physio in the first weeks. And arthrolysis after bone healing, that's the sequence of treatment. You cannot achieve union and full range of motion at the same time in many cases. Small articular defects, autograft and cartilage transplants is a good option. As we have seen, medium-sized defects, 3D partial joint resurfacing will be becoming more and more popular in the future. I'm quite confident. And for the large defects, we still need hinged arthroplasty, especially if you have no ligaments and structures and big bony defects. Restricted prosupination 4D analysis is very helpful and will also increase in use in the future. And for special situations, allograft joint transplantations may help in very, very selected cases. Thank you very much for your attention.
Dr. Rajeev may have to unmute.
Thanks, Professor KRETTEK. Nice to have you back to our teaching program. And it was an out-of-the-world presentation. We have some questions from the delegates. Would you like to take them, sir?
Sure.
Yeah. Ajit, in the meantime, I get the questions you ask.
I'll ask, how do you judge the radial head prosthesis height in image intensifier? How do you judge the radial head prosthesis height in image intensifier? Question.
Oh, I try to stress it under lateral stress, radial stress, and give it a bit of a play. And that's our way how we judge it.
The second question is, where exactly was the antibiotic spacer inserted?
In the case with the infected complex post-traumatic defect of the elbow.
Yes.
We usually make either one big chunk of cement and just leave it as it is, or we make a little hinge with an axis out of a screw. Doesn't make a big difference because there is so much movement after lysis when you insert the tumor prosthesis. This is very flexible.
Now, do you put it around the ulna or you put it around the radial head?
Should we just put it in between, in the defect? Not much sophisticated placement.
Thank you.
Professor, you showed a joint transplant. It looks like, I assume it is a non-vascularized. How do you expect this so good union in spite of being a non-vascularized joint transplant? How do you explain the healing?
It's a very good question. And when I was in training, we have done bulky allografts. And this bulky allograft had a thickness of the defect, and sometimes they were 4 or 6 centimeters thick, and they didn't heal in. But when you looked at the X-rays, you saw a few millimeter osseous integration of the allograft, of the transplant. So we changed our philosophy. We make the transplants very, very thin. a few millimeters, and you saw me excavating the radial head. So this radial head had only 4 millimeter wall thickness of bone. And this heals in very quickly. We have about 90 plus good bony ingrowths within 6 months. We have much problems with the cartilage, but with the bony ingrowths, with this thin 4 to 6 millimeter thickness is very reliable.
Thank you.
Pleasure.
Rajeev, you are muted.
Just check now. Is it okay?
Yeah, it's okay.
Professor KRETTEK, see, you did that olecranon plate fixation 2 times. Why not a tension band straight away in a diabetic lady, and that too after an infection?
Yeah, I think it's a very valid point. But the marketing of these plate devices is so aggressive, and we get failed fixations from all over. The problem with these plates is they are very disbalanced. They have 7 screws in the distal main fragment and 1.5 screws in the proximal main fragment. And these screws are not very good against pullout. See, the triceps just pulls it off. Tension band, much more effective. Yes, I agree. You're right.
But in that case, the olecranon was not reduced at all, I feel.
Yes, it was. Yeah, you're right. It was bad reduction, bad implant selection, bad perfusion by the patient, diabetic patient. So it's usually a combination of problems.
Sir, do you have any experience with excising the proximal fragment and putting the tricep to the distal fragment?
No.
We request the panelists to ask any questions to Professor KRETTEK. Any?
Yeah, so Professor, I think regarding the previous talk we had on radial replacement, we want to know what is your experience on the longevity of the radial head available in the market. So what is the largest, the longest follow-up you have?
Say it again. I didn't understand.
We want to know what is the longevity of the radial head process.
Oh, I don't know.
In your experience.
I don't know.
In your experience.
I don't know. I actually, I'm not a fan of radial head displacement. Whenever I can reconstruct, I'm more a rebuilder and reconstructor. But sometimes you need to do it, but I'm not a big fan of it.
So you try to fix all the fractures. Is that what you're saying? Irrespective of the combination?
I fix more fractures than others, but sometimes it's unavoidable. Sometimes you need to replace it.
You mean to say that initially you tried the prostheses and there were some failures?
Yeah, sometimes you have crushed radial heads, you need to replace them, no question. But there is a gray zone where some people say, okay, just get a prosthesis in. And I think there are many instances where you can repair it.
Professor KRETTEK, your experience about excision of radial head, maybe in your initial years, now you try to preserve them, but then any of your experience, the past experience of excision of the radial head?
Yeah, some do well. We have these migration problems with the lengths, and Dr. Fernandez knows much more about this. This can be an option, yes.
Professor.
The problem is always the long-term migration with height. Diego, what's your opinion? It's a question for you, actually.
What was the question?
Excision of the radial head.
Yes, at the beginning it was used before as I said before in my talk, when the first implant that came out was a celastic prosthesis of Swanson. And we used to resect non-reconstructible radial heads like Essex Lopresti things. We used to put this prosthesis as a temporary spacer because of the select. And then we removed it later, and then the elbow was stable. As I said before, the migration might be a problem in the heavy worker, and then you could treat with shortening osteotomy of the ulna. But if steels come now that we have prosthesis, we would put a prosthesis in to prevent proximal migration of the radius, especially if you have a longitudinal instability like in an Essex Lopresti. For just a comminuted fracture without damage of the interosseous membrane, I don't think it's a problem. It's most of these, they may do well, even with a little bit of ulnar plus, no pain and no limitation of forearm rotation. So I think it's individual. The decision is individual for every patient. You can't just generalize and say, I don't put prosthesis, I do this, I do that. It's a question of analyzing the clinical problem of each patient for, what they do, the work, if they're manual workers or not, if it's a pianist, is a musician, a violinist, it's just like that. But just to say, as Christian KRETTEK said, if you can reconstruct or repair a comminuted radial head with the implants we have now and the technology and the mini implants and the headlet screws and everything, it's a big step forward that we have done with internal fixation of the radial head. And we don't know the long-term results of prosthesis.
Diego, I have another question for you. When we see patients with radial head replacement, they always show, in my observation, they always show osteolysis or osteoporotic changes of the radial column. Why is this?
Well, it could be that it's just the Wolff's law, like if the prosthesis shaft is not loaded, like in a hip prosthesis, sometimes we used to see that in non-cemented prosthesis that you have an osteolytic gland. It means that the prosthesis is loading somewhere else, probably at the level of the neck. So mechanically, it's supported by the neck, and everything inside the shaft is mechanically not loaded. And then you have that, and it makes you feel uncomfortable. Is this a loosening or not? And the patient does well and doesn't have pain. So I think it's a question of that Wolff's law. I did a lot of cemented stent with a Judith bipolar prosthesis, which is the bipolar thing is you are unloading the shaft. And they did very well. There are long-term results with the Judith prosthesis, but nobody uses that one anymore. And George Orbe from Miami has this new aligned prosthesis that actually the neck head angle of the prosthesis is fixed according to the anatomy of each patient. He's got an alignment system for the axis of the radius, from the radial styloid to the radial tuberosity. It's a special alignment system. And then you fix the head. It's a bipolar, but then it's fixed. It's a monoblock prosthesis, but it seems that it's much less wear of the capitular radii with that. Again, if you ask me for long-term results, I can't tell. Everybody's trying to get better things.
Thank you, Professor.
Yeah, If there are no more questions, then we go to the next talk. Thanks, Professor KRETTEK, for your participation, and you have educated us. We are grateful. And we go to the next talk. Is our Anand Patil there?
Yes, sir.
Yeah,
Yes, sir.
Yeah.
Yes.
Yeah, go ahead.
Yes, sir. Yeah. Thank you, KOA, for having given me this opportunity to speak on arthroscopic arthrolysis. Yes, going back to the history, it was in around 1931. It was the Burman who, first performed elbow arthroscopy. Though the initial descriptions were in 1980s. What was difficult about this joint was about the confined space, the complex articulation, the proximity of major neurovascular bundle structures, which was so that's why initially it was more of a diagnostic tool, and then later on, after routine usage, it became more of a therapeutic. The advantages of an arthroscopy over any open procedure of elbow is, you have improved articular visualization, decreased post-operative pain, and then the faster post-operative recovery. Though the disadvantages are technically demanding because it's a very steep learning curve, and then the high risk of the neurovascular injuries. Although arthroscopy, I would not like to go much into the detail. Of course, anatomy is very important. Especially the medial side. The posterior medial, the nerves, that is ulnar nerve. And then the surface marking is very important so that you don't damage and the neurovascular bundles. And then of course the first thing is the soft spot where you inject the saline. So indications, the main indications are, of course, in the stiff elbow, the first 4 indications basically are the causes for the stiff elbow, that is presence of loose body, the osteophyte debridement, the synomectomy, and the capsular release. These are the various instruments which are used, 4 mm 30 degree scope, which can be used for the anterior, but for the posterior, it's good to have a 2.7 mm 30 degree scope. These are the various positions. I prefer going by the lateral position, which gives better visualization of both the anterior as well as the posterior compartment, as well as good for the anesthetist, will be very comfortable in case if we have to convert from a block to GA. So portal placement, first you would start with, going with, recognizing the soft spot in the triangle, which is formed by olecranon, medial epicondyle, and the radial head. And then you inflate the joint with the saline, and then make a small nick into the skin, and not deeper than that, and then spread it within your, your artery forceps, and then you make the portals. There are many portals, depending upon which part of the joint you're trying to visualize. But then let me talk about a few of them which are commonly used. Mainly it is the lateral portals, especially more so for, the anterior compartment because of the structures on the medial side. So among them, in the lateral, we have 3 portals. That is the mid-anterior lateral portal, then the proximal anterolateral portal, and the distal anterolateral portal. The medial portals, yes, for the anterior compartment, we have again 3 of those. And then the commonly used one is the mid-anterior medial portal. And then in the posterior, compartment, we use that is distal, that is tricipital, portal, that is, as you see, more proximally here on top, and then followed by these 2 accessory portals which are used. And so among all these, which have been marked with red, you can see these are the commonly used portals, which would suffice for doing most of the work. Now, when do you call an elbow as a stiff elbow? Stiff elbow is one where you have the normal range is from 0 to 140 degrees of flexion extension. Now it is reduced less than 100. Then we call it as a stiff elbow. And where you have even supination and pronation, which is around 90 degrees in either side, which is reduced to 50 and less. So that is an indication where you would like to think. Now, what are the causes for the stiff elbow? You have traumatic and atraumatic. we're more interested in the traumatic. So trauma is the most commonest, one of the most commonest cause. Other also are post-surgery. You can also see in various types of arthritis like osteoarthritis, or in case of hemarthrosis, and then post-septic and rarely congenital. Now, when do you consider for a surgery? Now, especially post-surgery, when do you use post-surgery elbow joint? We consider for surgery only after 6 months of a suitable rehabilitation treatment where it has been performed. Now, why arthroscopy over open procedure? Well, because studies shown by IF Kode et al. Have shown that the complication rates, which we see around 23% in open procedure, are not seen that commonly with arthroscopy, and then early rehabilitation and less pain post-operatively. The complication rate, as I said, as you see in open procedures, basically it's the cutaneous and muscular fibrosis, soft tissue injury, bruising, infection, and one more very important complication, that is heterotrophic ossification and nerve lesions. So procedure, so I prefer the lateral decubitus position, the brachial block, and ischemic cuff applied to around 250 degrees of pressure, ischemic time to around less than 2 hours. And sometimes you do need to consider the ulnar nerve release, especially in cases where you want to achieve more than 30 degrees of elbow motions. And in these cases, yes, you would like to go ahead and do a small release. So before you do that, you need to see that always you mark for the ulnar nerve. The surface marking is very important. The medial side, the ulnar nerve, the medial epicondyle, the olecranon process. On the lateral side, again, you would like to mark the radial head, then the lateral epicondyle. These markings are very important because it helps you in initial, inflection of the joint with saline, and later on followed by that. Now, what is the indication for the ulnar nerve release? In these cases, as I told you, where you are expecting more than 30 degrees of elbow motion, you can make a small incision of around 2 centimeters over the area, and you just need to release the nerve, and it's not that you really need to transpose it, anteriorly. The steps of arthrolysis, the anterior compartment, basically you have 2 compartments, that is the anterior compartment and posterior compartment. Would like to do the anterior compartment initially and then go to the posterior compartment. In each compartment, again, what is more important is the bony part is the one where you're going to handle, that is removal of the loose bodies, and then the osteophytes, then followed by what is known as soft tissue, synovectomy, and then later on it is the capsular release in the anterior compartment. So that's in the anterior compartment. You have the anteromedial portal for weaving, and then the anterolateral portal for working. And as I explained, about from the soft spot, you inflate the joint with saline, and then you use for anterolateral portal, you use a 14 mm catheter that is from the outside in technique. And then you perform a mild synovectomy. It is not, see again, when you're using your shaver, you're only going to use it with, without suction initially. And then later on, it is at the later stage, you may use a mild suction, because suction, you don't want that, you injure the capsule, because that can, cause complication and hamper the procedure. So basically, synovectomy and anterior capsulotomy improves the elbow extension, and then loose body removal and then the osteophyte removal are the one which actually help you in gaining more flexion. The one very important thing about anterior capsulotomy is, it is always done from medial to lateral, and when you're trying to do the last part, which is on the lateral side near the radial head, you have to be careful because of proximity to the posterior intraosseous nerve. And most of the time, you would like to leave it, part of it, you would like to leave it and only try to release it by manipulation. And always, when you have completed the anterior capsulotomy is by looking at, the appearance of the brachialis muscle. So here you can see the excision of the loose bodies as one of the first step, and then followed by that, you would like to plan and release the anterior capsule from medial to lateral. Now, on the posterior side, it is the central transpetal portal, which is used for as a weaving portal, and it's the posterolateral portal, which is used as a working portal. The posteromedial portal is most of the time avoided because of proximity to the alana. So again, so it's the same way there. You try to remove the loose bodies and then identify the osteophytes. Usually, it is in the olecranon fossa. You have those osteophytes as visualized here, and then as well as over the olecranon process. Here, how much to remove you identify by checking for the extension. And then once you are done with the olecranon fossa and the olecranon process, then you go into the medial and the lateral gutter. So we usually try to see that the passive mobilization of elbow is done following this procedure. And of course, you measure the final mobility. Skin portals usually like to close them with the mattress switches, usually don't prefer to use drains. Post-operative management is the splint is always applied in extension, discharge in 24 hours, splint for about 48 hours, and in the clinic you start the active and active assisted exercises are started, and rehabilitation is started as early as 7 to 10 days when you refer them to a physiotherapist. So advantages, it's a less painful and then lesser inflammation and then soft tissue injury in the elbow compared to the open procedure. Good results comparable to open surgery. So lesser percentage of complications as mentioned earlier and early rehabilitation. The only disadvantage is it's a complex technique with a long, learning curve. Specific orthoscopic instrumentations are necessary, so that's why it's expensive. Then you have the risk of, continuous drainage of portals and infection, risk of neurovascular injury, and of course, open procedure is a must during when you have implants in there. Thank you.
Dr. Rajeev has to unmute, yeah.
Yeah. Thank you, Dr. Anil. That was a new branch to me as far as I am concerned, being from the older generation. However, Dr. Satish, who is a good arthroscopic surgeon, may have some questions on this. He can.
No questions.
Professor KRETTEK, do you do any arthroscopy?
I have no good training. In many of these cases, we have implants where we have to manage, but I think it's a good add-on to have. We need to play all keys of the piano, black keys, white keys, and this is something we need to train and we need to have.
Yes. One more question. Do you have anybody in your department who would sort of read for you this 3D and 4D? This one, it is not very easy for us to interpret.
Yes.
Or do you do it yourself?
Yeah, I have a resident who is a natural talent in 3D software. He came already with good skills and continued working on it. We gave him resources and a playground so he could improve with this and establish models and concepts in order to make this more and more a part of our daily routine. We have now about almost 100 3D printed solutions and analysis, but it is still very time consuming to do a CT scan segmentation of the healthy side to the contralateral side. This takes days. We have hired students which are trained to do the segmentation process, but this will get more and more easy. There will be specific software in the future, and so this is probably coming more and more to clinical routine. Still, it's not covered by most of the insurances. So the extra work and the extra equipment we need and the implants we get printed by external companies, they all cost money. We do it for academic purposes and because we want to create and modify the musculoskeletal surgery of the future. So this is our motivation, but still it's not a thing which is hospital economically sensible.
Okay, thank you.
Anil Patil. Hello.
Yeah, go ahead.
So this myositis is one of the cause for ankylosis at elbow. Your arthroscopy, how can you treat for that myositis?
Yes, sir. Actually, there is no role of arthroscopy for myositis ossificans because this is extracapsular. Basically, it's an injury to the brachialis muscle, which is anterior to the anterior capsule. Because of the injury and bleeding into the brachialis muscle, which causes the myositis. So arthroscopy as a role is not there. Why? Because any injury to the brachialis muscle, you are very close to the neurovascular bundle anteriorly. So at least I think as a beginner or somebody who is not very experienced would not like to do anything, for osteo. At least I do not have any experience with myositis ossificans.
Only intra-articular stiffness is
yes. Yes.
Oh.
Do you give special medication for preventing ossifications?
Sir, I use indomethacin.
Okay.
I mean, that's something which is economical and easily available with us. So we usually try to give indomethacins to these people for about 3 weeks.
Radiation? Does radiation has a role?
Yes, radiation does have a role, but then availability is a problem for us.
Sorry, Diego.
Oh, no, I just wanted to ask about radiation. I think it's both things are good. Indomethacin for about 3 weeks and radiation pre and post-op, just two doses. I think it's 100 G or something like that. I'm not a radiologist, but it's useful.
So, do we have any more questions? The panel. Rajeev, Naik, Dr. Ajit.
No, I think they have answered all questions.
So if no questions, we'll go to the closing remarks by Dr. Bharath.
Yeah.
And then we can close the session. Dr. Bharath, sir, you can take over.
Good evening, everyone. It's been a wonderful evening, very informative. On the outset, I would like to appreciate the efforts of Dr. Chandrashekar, President of Karnataka Orthopaedic Association, in regularly hosting these events. And every month it is increasing in leaps and bounds, the content which is being shared amongst all of us. First of all, I would like to thank our guest faculty, Professor Diego Fernandez and Professor KRETTEK, who shared their extensive insights about elbow injuries with all our viewers. I also like to thank our faculty from our state, Dr. Anil Patil, Dr. Shankar KURPAD, and Dr. PURUSHOTHAM, for sharing their experiences with us. I would like to thank the moderators, Dr. Rajeev Naik and Dr. Ajit Kumar, for conducting a wonderful session. I would like to thank our panelists, Dr. Vishwas Mundewadi, Dr. Ashwin Kumar Singh, Dr. Roshan Kumar, and Dr. Madhukar KT. Thank you very much, sir. And a special thanks to Dr. Satish Shervegar and Dr. Vamsi Krishna in organizing and conducting this event. Last but not the least, I would like to thank our event sponsors, Alembic Pharmaceuticals, for continuously supporting our webinars. Thank you one and all. And I also like to thank the delegates who attended this meeting and made it a grand success. Thank you all.
Thank you all.
Thank you.
Thank you, sir.
Bye-bye.
you.
Night,
Bye, sir.
night.
Thank
Thank you
you,
very
sir.
much.
Good night.
Good.
Good night.
Bye. Bye.
Disconnect ಮಾಡಿ